Welcome to maternity nursing. Hyperemesis gravidarum is extreme nausea and vomiting of pregnancy during the first half of a pregnancy. It's more severe than morning sickness of early pregnancy and occurs in only 0.1% of pregnancy. Signs and symptoms: intractable nausea and vomiting, which is nausea and vomiting that is not relieved by normal measures. Dehydration, weight loss, electrolyte imbalance. Etiology: there's no known etiology. Psychological and physiological causes are being researched at the present time. Nursing care. Nursing care consists of IV fluid therapy with glucose, electrolytes, and vitamins, monitoring of daily weights, INOs every shift, vital signs, and check hydration and nutritional status. Diabetes and pregnancy. Pregestational or insulin-dependent diabetes mellitus is when a woman has diabetes prior to getting pregnant. Gestational diabetes is the development of diabetes during pregnancy. Control of the blood sugar is the key to a healthy pregnancy with a diabetic mother. Poor insulin control can lead to neonatal macrosomia, hypoglycemia, hyperbilirubinemia, delayed lung maturity resulting in respiratory distress syndrome, and increased incidence of fetal anomalies. Gestational diabetes can often be controlled by diet, but frequent glucose monitoring is required. Some gestational diabetics will need insulin for control. Effects of pregnancy on diabetes. Insulin demands increase during the first half of the pregnancy. Insulin demands may increase or decrease during the last half of pregnancy. Immediately post-delivery, insulin demands drop significantly. Frequent and consistent monitoring of blood glucose levels in insulin-dependent diabetic mellitus mothers is crucial to glucose control. Oral hypoglycemic medications are contraindicated in pregnancy, but they are currently doing research on several oral hypoglycemics. For testing purposes, insulin is the only hypoglycemic medication that can be used in pregnancy. Diabetic mothers, whether gestational or pregestational, are usually induced at 38 to 39 weeks gestation. Placental complications. Placenta previa is the abnormal implantation of the placenta in the lower uterine segment. It occurs in 0.5% of all pregnancies. It is described as to where the placenta has implanted. Total previa, the placenta covers the entire cervical os. Partial previa, incomplete covering of the cervical os, often reported as a percentage of the coverage. A marginal previa, only the edge of the placenta extends to the cervical os, but it may extend into the os as the cervix dilates during labor. Low-lying placenta is when the placenta implants in the lower uterine segment. The key to placenta previa is to monitor it through the pregnancy. It is diagnosed with an ultrasound. Risk factors for placenta previa: history of a previous placenta previa, history of a previous cesarean section, history of an induced abortion. Signs and symptoms. 70% of women have painless, bright red bleeding. 20% have bleeding associated with uterine activity. Previa should be suspected with bleeding after 24 weeks gestation. Usually it's diagnosed with an ultrasound. Oftentimes it is noted during the second trimester. A follow-up ultrasound will be done later in the third trimester to localize the placenta and make a decision for delivery. If the placenta is near or on top of the cervical os, delivery cannot be done vaginally. Treatment. Never do a vaginal examination if there's frank bleeding. We'll do continuous fetal monitoring, lab work, monitor the vaginal bleeding, and if she's preterm, expectant management. Expectant management is bed rest, serial ultrasounds, serial CBCs, closely monitoring the amount of vaginal bleeding. If minimal, we may continue to watch until term. If moderate to heavy, we may need to expedite the delivery. If she's term, we'll expedite the delivery. If she has a total or partial previa, we'll do a C-section. If marginal or low-lying, vaginal delivery may be attempted via a double setup. This means we'll do a vaginal delivery with C-section equipment in the room in a C-section room. Make sure the blood products are available if needed. Abruptio placenta, the detachment of all or part of the placenta from the implantation site after 20 weeks gestation and prior to delivery of the infant. Abruptio placenta accounts for approximately 15% of all neonatal deaths. 50% of these are due to prematurity. Abruptio placenta is graded. Grade 1 abruptios, the woman has vaginal bleeding, perhaps with uterine tenderness and mild tetany, but neither the mother or fetus is in distress. Approximately 10% to 20% of the total placenta is detached. A grade 2 abruptio, the woman has uterine tenderness and tetany, with or without external evidence of bleeding. The mother is not in shock, but the fetus is in distress. Approximately 20 to 50% of the total area is detached. A grade 3 abruption, the woman has uterine tetany, the woman is in shock, although bleeding may not be obvious, the fetus is in severe distress or dead. Often the woman has coagulopathy, greater than 50% of the surface is detached. Risk factors. History of previous abruption, hypertension, blunt abdominal trauma, cocaine use, a previous C-section, multiparity, partial abruption of this pregnancy. Treatment. Admission, continuous fetal monitor. Lab works will include routine labor and delivery labs, plus a PT, PTT, fibrinogen, because clotting defects occur in 10 to 30% of abruptions, a Kleihauer-Betke to measure the amount of fetal hemoglobin present in the maternal circulation. Delivery is usually via C-section in the instances of a grade 2 or grade 3 abruption. In the case of fetal death, delivery method is determined by the mother's condition. The normal anatomy of the placenta versus placental abruption is what you're seeing here. And if you look at the placental abruption, you can see the actual abruption area. Heart disease in pregnancy does not refer to coronary artery disease. 1% of all pregnancies are complicated by heart disease. Heart disease is the leading cause of non-obstetric maternal mortality. Cardiac disease ranks 4th overall as the cause of maternal mortality. Rheumatic fever is responsible for 50% of all cardiac complications. Congenital anomalies and mitral valve disease are the next most common. Other types of heart disease are uncommon. Mitral valve prolapse is the most common heart problem found in pregnancy. In patients with mitral valve prolapse, one or both leaflets of the mitral valve are enlarged. This enlargement causes uneven closing of the mitral valve. This produces a clicking sound on auscultation. In some instances, the delay is so great that blood flows back into the atrium. This is called mitral regurgitation. This may cause a murmur. The New York Heart Association's functional classification. Class 1 is asymptomatic at normal levels of activity. Class 2 is symptomatic with increased activity. Class 3 is symptomatic with ordinary activity. Class 4 is symptomatic at rest. Be aware that a woman with class 1 heart disease may move to class 2 or 3 during pregnancy. It is rare to see class 2 to class 4 cardiac disease in pregnancy unless one works in a tertiary care center with OB/ICU capabilities. Most women with cardiac disease need good antenatal counseling before becoming pregnant. Treatment for mitral valve prolapse is prophylactic antibiotics in labor. Treatment for other cardiac diseases are as follows: class 3 to class 4, antibiotics Q6 while in labor, ampicillin and gentamicin are the drugs of choice. If allergic to penicillin, vancomycin is the drug of choice. Class 1 to class 2, antibiotics times 1 when in active labor, ampicillin or vancomycin depending on allergy status. Hypertensive disorders of pregnancy. The term pregnancy-induced hypertension, PIH, is no longer being used in current literature. Gestational hypertension, formerly called PIH, it is the occurrence of blood pressure elevation after 20 weeks gestation to 140/90 for the first time during pregnancy without the accompanying proteinuria. It can progress to preeclampsia with the development of proteinuria and other diagnostic indicators. It is referred to as transient hypertension of pregnancy if preeclampsia is not present at delivery and blood pressure returns to normal by 12 weeks postpartum, or it is diagnosed as chronic hypertension if blood pressure elevation persists beyond 12 weeks postpartum. Diagnosis of gestational hypertension is used during pregnancy only until criteria arise that define a more specific diagnosis. Preeclampsia, eclampsia is a pregnancy-specific syndrome usually occurring after 20 weeks gestation, determined by an increase in blood pressure and proteinuria. May occur earlier than 20 weeks gestation in the presence of hydatidiform mole or hydrops. Eclampsia is the occurrence in a woman with preeclampsia of seizures that cannot be attributed to other causes. HELP syndrome is a hypertensive state in pregnancy that occurs in a small number of severely preeclamptic women who have a certain set of abnormalities in addition to signs and symptoms of preeclampsia. These are hemolysis, elevated liver enzymes, and low platelets. Preeclampsia superimposed on chronic hypertension is the occurrence of preeclampsia in a woman who enters pregnancy already in a hypertensive state. Chronic hypertension is the presence of hypertension in a woman prior to getting pregnant. Hypertension is defined as a blood pressure of 140/90 or greater. A rise in blood pressure of 30/15 is no longer diagnostic, but if your patient has such a rise in blood pressure, close monitoring for other signs and symptoms of preeclampsia is warranted. Mild preeclampsia, a blood pressure of 140/90 to 160/110, proteinuria greater than 300 milligrams but less than 2 grams in a 24-hour urine, or 1+ to 2+ on a urine dipstick in the absence of a UTI. Severe preeclampsia, blood pressure greater than or equal to 160/110, proteinuria greater than 2 grams in a 24-hour urine, or 3+ to 4+ on a urine dipstick in the absence of a UTI. Other signs and symptoms. Headache is more common in severe preeclampsia, though may be present in mild preeclampsia. Visual disturbances, usually with severe preeclampsia, blurred vision, spots before her eyes, right upper quadrant pain or epigastric pain, usually with severe preeclampsia. Reflexes may or may not have hyperreflexia in mild preeclampsia, but will have 3+ or greater reflexes in severe preeclampsia. Clonus may be present in severe preeclampsia. Risk factors. First, pregnancy, a family history of preeclampsia, diabetes, systemic lupus erythematosus, history of chronic hypertension, kidney disease, multiple pregnancy, maternal age less than 20 or greater than 35, history of preeclampsia in a prior pregnancy, new father of the baby for this pregnancy. The etiology of preeclampsia is still unknown, though there are several theories under investigation at this time. See this handout that I have posted for the pathophysiology and the pathophysiologic changes associated with preeclampsia. Treatment. Delivery is the only cure for preeclampsia. Preeclampsia is treated with magnesium sulfate for seizure precautions. Magnesium sulfate is given IV piggyback. 4-gram loading dose is given over 30 minutes, then a 2-gram per hour maintenance dose is begun. Foley catheter with urometer is inserted to measure urine output. Vital signs are checked every 15 minutes for the first hour and during the loading dose, then every hour while the infusion is going. Reflexes, I&Os, heart and lung sounds, peripheral pulses, and neurochecks are done with vital signs. Signs and symptoms of magnesium sulfate toxicity are decreased reflexes and decreased respirations. Antidote to magnesium sulfate is calcium gluconate. A magnesium level will usually be drawn 6 to 8 hours after the loading dose, then every 6 hours thereafter. Continuous fetal monitoring is done during the loading dose and for several hours after the maintenance dose is begun. If the mother is in labor, continuous monitoring is done until delivery. If expectant management, you may do daily non-stress tests with fetal heart tones every shift until labor begins. The treatment of choice for eclampsia is a 2-gram bolus of magnesium sulfate, either IV push or IM. The IV push method is preferred. Never give Methergin to a patient with hypertension. Nursing care for preeclampsia also includes complete bed rest in a dim, quiet room. Limit visitors, and if severe preeclampsia, have all phone calls routed through the nursing station. This is done because preeclamptic women have an irritable nervous system, and frequent loud noises and lots of visitors can lead to eclampsia in this patient. Seizure precautions are also necessary. Padded bed rails, padded tongue blade, magnesium sulfate 2-gram injectable, and calcium gluconate at the bedside. Preterm labor, cervical changes and uterine contractions occurring between 20 and 37 weeks gestation. Etiology. Maternal behaviors: smoking, substance abuse, alcohol or illegal drugs, poor nutrition, work, fatigue, short interpregnancy intervals, sexual activity. Maternal characteristics: young or older age, previous preterm birth, short stature, short cervix, uterine anomalies, diethylstilbestrol exposure, prematurely dilated cervix, low pre-pregnancy weight, race African American or Hispanic, unmarried, low socioeconomic status, victim of domestic violence. Other factors: inadequate support systems, stress, uterine irritability, multiple gestation, late or no prenatal care, preterm premature rupture of membranes, anemia, infection, catecholamine release, decreased progesterone production, decidual cell production, prostaglandin synthesis, cytokine release. Risk factors. Demographic risks: non-white race, age less than 17 years or greater than 35 years, low socioeconomic status, unmarried, less than high school education. Biophysical risk: previous preterm birth or labor, second trimester abortion, more than 2 spontaneous or therapeutic, stillbirths, grand multiparity, short interval between pregnancies, less than or equal to 1 year since the last birth, family history of preterm labor and birth, progesterone deficiency, uterine anomalies or fibroids, uterine irritability, cervical incompetence, trauma or shortened length, exposure to DES, which is diethylstilbestrol, or other toxic substances, medical diseases, diabetes, hypertension, anemia, small stature, less than 119 centimeters in height, less than 45.5 kilograms, or underweight for height. Current pregnancy risks: multifetal pregnancy, hydramnios, bleeding, placental problems, previa or abruptio, infections, pyelonephritis, recurrent UTIs, asymptomatic bacteriuria, bacterial vaginosis, chorioamnionitis, gestational hypertension, premature rupture of membranes, fetal anomalies, inadequate plasma volume expansion, anemia, behavioral psychosocial risks, poor nutrition, weight loss or low weight gain, smoking greater than 10 cigarettes a day, substance abuse, alcohol, illicit drugs, especially cocaine, inadequate prenatal care, commutes of more than 1.5 hours each way, excessive physical activity, heavy physical work, prolonged standing, heavy lifting, young child care, excessive lifestyle stressors. Signs and symptoms: contractions occurring every 10 minutes or less with or without pain, low abdominal cramping, intermittent feelings of pelvic pressure or urinary frequency, low backache. Signs and symptoms continued: increased vaginal discharge, leaking of amniotic fluid. Treatment: bed rest, continuous fetal monitoring and contraction monitoring, use of tocolytics. Ritodrine, also called Udapar. When giving ritodrine, frequent assessment of the heart and lungs are essential. Also assess fetal heart rate continuously. Ritodrine is seldom given because of the cardiac side effects. It is the only drug FDA approved for preterm labor. It is given IV piggyback via an infusion pump. Terbutaline, breathine. You must assess breath sounds and heart sounds frequently. Do not give if heart rate over 120. Breathine is usually given sub-Q for preterm labor, 0.25 milligrams sub-Q every 15 to 30 minutes times 3 doses. If contractions stop, you may wean to a PO dose, 2.5 to 5.0 milligrams PO every 4 to 6 hours. Magnesium sulfate for preterm labor. You must monitor vital signs, reflex, and INOs every hour while using. For preterm labor, a loading dose of 4 to 6 grams is given over 30 minutes, then 2 to 4 grams per hour maintenance dose. Magnesium sulfate is always given IV piggyback via an infusion pump. Betamethasone for fetal lung maturity. Give 12 milligrams IM times 2 doses 24 hours apart. Postpartum hemorrhage. Postpartum hemorrhage can be classified as the loss of more than 500 cc's of blood after a vaginal delivery or a loss of more than 1,000 cc's of blood after a C-section. Alternate definition is a 10% change in the hematocrit between admission and postpartum. An acute, aka early or primary hemorrhage, occurs within 24 hours of birth. Secondary or late occurs more than 24 hours after birth, but less than 6 weeks postpartum. Postpartum hemorrhage is the leading cause of maternal morbidity and mortality in the United States. Causes: immediately identifiable causes. Uterine atony, marked hypotonia of the uterus. Risk factors for uterine atony are multiple gestation, polyhydramnios, magnesium sulfate use in labor, prolonged labor with the use of Pitocin, previous incidence of uterine atony, multiparity, and use of conduction anesthetics. Lacerations of the genital tract. Risk factors for lacerations are large infant, precipitous birth, instrument-assisted birth. Retained placenta. Non-adherent retained placentas. Causes: partial separation of a normal placenta, entrapment of a partially or completely separated placenta. Mismanagement of the third stage of labor, poor separation of the placenta is common in very preterm births, 20 to 24 weeks. Adherent retained placentas. Placenta accreta, a slight penetration of the myometrium by the placental trophoblast. Placenta increta, deep penetration of the myometrium by the placenta. Placenta percreta, a perforation of the uterus by the placenta. Adherent retained placentas occur in 1 out of 12,000 births. Of these, 15% are associated with placenta previa. Risk of adherent placentas increases to 67% with 4 or more C-sections. Risk of adherent placentas produces a 24% risk with 1 previous C-section. If these women are not diagnosed prior to delivery, they are at high risk for maternal mortality. These patients usually need a hysterectomy to stop the bleeding. Most accretas are diagnosed by ultrasound prior to delivery. Increta and percreta can be diagnosed with an MRI. These women are almost always previous C-sections. When setting up for the C-section, a set of hysterectomy instruments need to be available and opened for delivery. Inversion of the uterus, the turning inside out of the uterus and protrusion of the uterus from the cervix or vagina. This is a medical emergency. The uterus must be replaced quickly. Tocolytics or anesthesia may be necessary to replace the uterus. Risk factors for inversion of the uterus are vigorous fundal pressure, excessive traction on the cord. Uterine atony can sometimes be a contributing factor. Subinvolution of the uterus. Failure of the uterus to begin involution. Involution is the process by which the uterus contracts down and returns to its normal prepregnant size. Placenta previa or abruptio placenta. Nursing care for postpartum hemorrhage. Assessment of vital signs, fundus, bleeding, bladder status, heart and lung sounds, capillary refills, and pulses. Vital signs may not show a significant change until the patient has lost 30 to 40% of her blood volume. This is true because of the hypervascular state of pregnancy. If the fundus is bulgy and shifted to the right, the patient most likely has a full bladder. When doing postpartum assessments, check for color and amount of lochia. Check the patient's heart and lung sounds before labor, during labor, and immediately after labor during the recovery period. The same is true of capillary refills and peripheral pulses. Nursing care for postpartum hemorrhage continued. Maintain a patent IV. If the labor IV is still patent, maintain it. If not, start a new IV immediately. Obtain appropriate lab studies, CBC coagulation studies type and cross-match. Notify the physician of any abnormal bleeding or assessment findings immediately. If the patient has a firm midline fundus and is still bleeding, suspect lacerations or hematomas. Medications for postpartum hemorrhage. Pitocin 20 units to 40 units in 1,000 cc's of Ringer's lactate. Run at 125 to 200 cc's an hour after checking heart and lung sounds. Word of caution, pregnant women are prone to pulmonary edema if you force fluids. Methergin 0.2 milligrams IM every 2 to 4 hours times 5 doses. Do not give if patient was hypertensive. Hemabate 0.25 milligrams IM every 15 to 90 minutes times 8 doses. Check for a history of asthma before giving. Please review the postpartum hemorrhage flowchart I posted, and remember, panic is never an option. Hemorrhagic shock is an emergency situation in which the perfusion of body organs is severely compromised and death may occur. Signs and symptoms. Minor changes in vital signs until significant blood loss, loss or decrease in pedal pulses. Cold, clammy skin does not appear until significant blood loss. Excessive blood loss for the stage of postpartum. As blood volume decreases, pedal pulses will weaken and disappear. When blood volume gets low enough for the classic signs and symptoms of shock, this patient is already in serious trouble. Nursing care of hemorrhagic shock. Frequent vital signs. Fluid replacement, 3 cc's for every 1 cc lost. Be very careful with fluid replacement. Replace fluids with crystalloids, i.e. Ringer's lactate or normal saline. Only use normal saline if giving blood. Remember, this patient is prone to pulmonary edema. Assess heart and lung sounds carefully. Comfort measures for the patient. Reassure the patient. Prepare this patient for surgery as necessary. Deep vein thrombosis. Thrombosis results from the formation of a clot or clots inside a blood vessel. Thrombophlebitis is inflammation of a clotted vessel. 3 types of thromboembolic conditions. Superficial venous thrombosis is involvement of the superficial saphenous venous system. Deep vein thrombosis, involvement varies but can extend from the foot to the iliofemoral region. Pulmonary embolism occurs when part of a blood clot dislodges and is carried to the pulmonary artery where it occludes the vessel and obstructs the flow of blood to the lungs. Incidence varies from 0.5 to 3 women in 1,000. Incidence has declined in the last 20 years due to early ambulation. Causes: venous stasis, hypercoagulation. Both of these conditions are present in the pregnant patient and continue into the postpartum period. Risk factors: C-section, obesity, history of venous thrombosis or varicosities, maternal age older than 35, multiparity, and smoking. Signs and symptoms. Superficial vein thrombosis is the most frequent form of postpartum thrombophlebitis. Pain and tenderness in the lower extremities may be found. Exam may reveal warmth, redness, and an enlarged, hardened vein over the site of the thrombosis. Signs and symptoms continued. Deep vein thrombosis is more common in pregnancy, characterized by unilateral leg pain, calf tenderness, swelling. Physical exam may reveal warmth. Some women have a large clot and few symptoms. Positive Homan sign is often present. Further evaluation is always necessary because calf pain may be attributed to other causes. Pulmonary embolism is characterized by dyspnea and tachypnea. Other signs and symptoms are apprehension, cough, tachycardia, hemoptysis, increased temperature, and pleuritic chest pain. If your patient has any type of embolus either during pregnancy or postpartum, be on the lookout for symptoms of PE. Any patient with an embolus is at risk for PE. Remember, physical exam is not a sensitive indicator for embolus. Venography is the most sensitive test but is seldom used, especially during pregnancy. It exposes the patient and fetus to ionizing radiation. Real-time or colored Doppler ultrasounds are the most common tests used. For PE, a ventilation perfusion scan, Doppler ultrasound, or pulmonary arteriogram can be done. Nursing care. Provide anticoagulation therapy and analgesia as prescribed by the physician. Monitor coagulation panels as ordered. Inspection and palpation of the affected area. Palpation of peripheral pulses. Checking Homan's sign. Measurement and comparison of leg circumferences. Inspection for signs of bleeding. Monitor for signs of PE. Assess woman and her family for understanding about the diagnosis and their ability to cope during the extended recovery period. Reassure the patient and her family. Saphenous vein thrombosis. Analgesics usually are non-steroidal anti-inflammatory agents. Deep vein thrombosis, usually IV heparin therapy for 5 to 7 days, then oral anticoagulants, warfarin, which are started while on heparin and then continued for approximately 3 months. Coumadin is contraindicated in pregnancy, so pregnant women with DVTs get IV heparin until they deliver, though sometimes they can be weaned to sub-Q heparin. Postpartum infection occurs in approximately 6% of all births in the United States. The incidence is 5 to 10 times higher in post-op C-sections. Any clinical infection of the genital canal that occurs within 28 days after miscarriage, induced abortion, or childbirth, or the presence of a fever of 100.4 degrees Fahrenheit or more on 2 consecutive days during the first 10 postpartum days, not counting the first 24 hours. Risk factors: prenatal, history of previous venous thrombosis, UTI, mastitis, pneumonia, diabetes, alcoholism, drug abuse, immunosuppression, anemia, and malnutrition. Intrapartal risk factors: C-section, prolonged rupture of membranes, chorioamnionitis, prolonged labor, bladder catheterization, fetal scalp electrode or intrauterine pressure catheter, multiple vaginal exams after rupture of membranes, epidural anesthesia. Intrapartal risk factors continued: retained placental fragments, postpartum hemorrhage, episiotomy or lacerations, or hematomas. Causes: endometritis, wound infection, urinary tract infection. Signs and symptoms: endometritis, the most common cause of postpartum infection. Fever, chills, anorexia and nausea, fatigue and lethargy, foul-smelling profuse lochia, pelvic pain and/or uterine tenderness. Wound infection: any infection of the C-section site or infection of the episiotomy or laceration site. Erythema, warmth, edema, tenderness, seropurulent drainage, wound separation, fever, pain. Urinary tract infection: an infection of the urinary tract. Low-grade fever, dysuria, frequency, flank tenderness, hematuria, pyuria, urinary retention. Nursing care: lab work, CBC, blood cultures, uterine tissue cultures, give antibiotics as ordered, adequate hydration and pain relief. Be sure to draw the blood cultures before beginning antibiotics. Assessment of lochia, vital signs, and changes in patient's condition continue during treatment. Comfort measures depend on the woman's symptoms: cool compresses, warming blankets, perineal care, sitz baths. Remember, the most effective treatment for infection is prevention of the infection. Patient teaching: good perineal hygiene, thorough hand washing, signs and symptoms to notify the doctor of: foul-smelling lochia, abnormal change in color and consistency of the lochia, fever of 100.4, redness or swelling at incision sites, drainage from C-section incision site. Women at risk need extra reinforcement of signs and symptoms to watch for. When teaching the woman at risk, be sure and emphasize good perineal care even at home, good hand washing, and the appropriate care of C-section incisions. Newborn complications: prematurity, the delivery of an infant prior to 37 weeks gestation. Most common complications are respiratory distress related to immature lungs, difficulty regulating body temperature, infection, and hemorrhage. Postmaturity, delivery after 42 weeks gestation. Complications associated with postmaturity is meconium aspiration. Respiratory distress is a disorder caused by the lack of surfactant in the lungs. This lack causes the alveoli to collapse after each breath. Meconium aspiration syndrome is a type of respiratory distress caused by the inhalation of meconium into the lung fields. It is usually associated with term and postmature infants. Meconium-stained infants should be suctioned on the perineum at delivery with either a DeLees suction or a suction catheter. Visualization of the cords via an ET tube can be done by the neonatologist at delivery. Transient tachypnea of the newborn occurs when the infant fails to clear excess fluid from the airway at delivery. Primarily occurs in term infants delivered by C-section. Size problems: large for gestational age and small for gestational age. Both large for gestational age and small for gestational age babies need to be assessed frequently for hypoglycemia. Due to their size, they are at risk for developing hypoglycemia, and they may also have trouble maintaining their temperature. When transferring any baby from an incubator or warmer to an open crib, the infant needs a shirt, clean diaper, and a warm cap. Small for gestational age babies and preemies need a double thickness cap. Grief and loss related to pregnancy. The most appropriate thing to say to a woman or family who has had a loss of pregnancy is, "I am sorry." "I'm sorry" is the best thing to say if the woman has had a miscarriage, fetal demise, or a neonatal death. With a fetal demise, always offer to let the parents see and hold their baby. This allows the family to say goodbye to their baby. You may also offer information on some of the support groups available in our area for patients who have had a fetal demise, a neonatal death, or have lost a child by some other means. Thank you.